Optimal nutrition is important for maintaining a healthy immune system and preserving the overall general health. However, several factors make this a challenge for people with HIV. Weight loss and malnutrition are common due to the complications such as anorexia, changes in metabolism, malabsorption, and chronic diarrhea. HIV-related factors such as depression, loss of appetite, impaired taste or smell, or stomach upset can prevent and affect the individuals from eating enough. Even people with HIV who consume adequate diets might experience chronic diarrhea or vomiting from drug treatments or opportunistic infections, and this can lead to nutrient loss. Combined, these factors can lead to a nutrient deficiency, and this can impair the immune function and lower the body's resistance to infection. New infections, in turn, can further impair the nutritional status, creating a vicious cycle that promotes the progression of the disease. Moreover, some individuals with HIV might have increased nutrient requirements for other reasons, including pregnancy or because they are infants or growing children. These issues underscore the importance of ensuring adequate intake of vitamins and other nutrients to help to maintain the health. Other steps towards optimal health include maintaining a healthy lifestyle, avoiding the use of illicit drugs, alcohol, and tobacco, as well as engaging in moderate physical activity. In moderation, being active has been found to support the immune function, reduce the potential of metabolic abnormalities, and decrease the risk of acute infection. It can also boost muscle mass, which can be useful for countering the HIV-related lipodystrophy. Regular physical activity is associated with decreased levels of skeletal muscle inflammatory proteins, as well as reductions in several other important markers of inflammation. These biomarkers bear strong correlations with adverse conditions such as cardiovascular and metabolic disease, like insulin resistance, underscoring the value of moderate physical activity. Moderate activity can also eliminate obesity. This presents additional health-related benefits, particularly since obesity is associated with impaired immune function. Along with a host of other heart problems, prolonged more than 1.5 hours of high-intensity exercise is not recommended for people with HIV, as it might have an immune-suppressing effect. Given the deteriorating effects that HIV and AIDS has on the immune system and the nutrition status, it's not surprising nutritional supplements have been shown to be extremely beneficial for patients with HIV. Taking vitamin supplements lowered the risk of HIV disease progression in several studies. The use of vitamin supplements has also been associated with improved pregnancy outcomes in HIV-infected pregnant women, increased appetite in HIV-infected children, and better health and survival in children with HIV. In addition, nutritional supplements have been found to improve comorbidities that are associated with HIV. In HIV-infected patients who are being treated for tuberculosis, for example, the consumption of micronutrients, vitamin A, B complex, C, E, and selenium, corresponded with a lower risk of tuberculosis recurrence and a significant lower incidence of peripheral neuropathy. In a recent study in children with HIV, a daily supplement of vitamin A, B complex, C, D, E, and folic acid with zinc, iron, and copper corresponded with faster recovery from diarrhea episodes and pneumonia. Antioxidants are widely known for their health benefits, and they might be particularly important for people with HIV. Many scientific studies have examined a wide range of nutrients and supplements for use in HIV and AIDS. Under normal circumstances, metabolic processes in the body generate free radicals at low and moderate concentrations, and these reactive oxygen species are not harmful, but instead they have a variety of beneficial functions. At high concentrations, however, they become extremely destructive. Normally, the human body keeps these levels in check by neutralizing the free radicals with its own natural antioxidant defenses. However, some conditions can boost the production of free radicals and create oxidative stress, a condition where the body's antioxidant defenses are unable to neutralize the overwhelming quantity of the free radicals being produced, and this can lead to cellular damage and the development of disease. HIV is associated with substantial oxidative stress, and reactive oxygen species participate in the progression of HIV to AIDS. As HIV progresses, antioxidant levels decline. Compounding the problem further is the fact that various HIV treatments have been shown to increase the oxidative stress. Combined, these factors create an unhealthy environment that could further be exacerbated by the inadequate intake or the poor absorption of nutrients that is commonly associated with HIV. Antioxidant micronutrient deficiencies are common among people with HIV. Reduced serum levels of vitamin E, a powerful antioxidant, has been associated with a higher risk of developing AIDS. Antioxidant supplements have been found to counteract some of the damaging effects that are associated with HIV. Taking supplements of vitamin E and vitamin C for 3 months lowered the oxidative stress among patients with HIV, and it produced a trend towards a decrease in viral load. High serum levels of vitamin E have been linked with a slow progression of HIV. In a large study in Tanzania involving 1,075 pregnant women with HIV, taking a daily multivitamin combination consisting of vitamin C, E, and various B vitamins and folic acid improved the CD4, CD3, and CD8 cell counts, and it lowered the risk of fetal death, low birth weight, preterm birth, and small size for gestational age. Other antioxidants have also shown benefit for people with HIV. A study involving 331 AIDS patients found that when patients received supplements including various carotenoids, as well as multivitamins and minerals, the mortality rates were lower and the CD4 T cell counts were higher compared to the patients who received the same supplementation without the carotenoids. In HIV-infected patients following a stable HAA-RT regime, the use of broad-spectrum, high-dose micronutrient supplementation with antioxidants corresponded with a 24% increase in the CD4 cell count. Other important antioxidants have been highlighted in the HIV literature, and these include glutathione, which is thought to be an extremely important antioxidant for HIV-infected patients because it appears to interfere with the HIV's entry into its target cell. Glutathione deficiency is a common finding in HIV, and is associated with compromised T cell function and decreased survival. Some nutrients that offer health benefits and also assist in the production of glutathione are N-acetylcysteine. N-acetylcysteine is of particular interest for people with HIV and AIDS because it reinstates the glutathione levels, and it's been found to maintain the glutathione concentrations. It improves the T cell count and it reduces the viral load in patients with advanced AIDS. In many studies, the use of N-acetylcysteine oral supplementation has correlated with better quality of life and patient well-being. A study involving 81 HIV-infected patients showed 8 weeks of oral N-acetylcysteine supplementation correlated with significant improvements in whole blood glutathione concentrations, as well as increased T cell glutathione levels. The N-acetylcysteine is known for exerting antioxidant effects against the activity of glycoprotein 120, a HIV protein that induces oxidative stress during the infection of the macrophages, which are a type of white blood cell. Green tea contains compounds called catechins, and these have powerful antioxidant properties. The most abundant catechin in the green tea is epi-galligo-catechin gallate, or EGCG, and it's been found to suppress HIV. It was found the EGCG can bind to the T cells and block the virus from attaching to them. When HIV comes in contact with the helper T cell in the human body, GP120 on its surface binds to a CD4 receptor on the surface of the T cell, ultimately leading to infection. In several studies, the EGCG blocked the attachment of the GP120 to the CD4 cell with varying degrees of inhibition. The EGCG also appears to lower the risk of HIV transmission. Normally, fibrils in human sperm collect HIV virus and deliver them to the target cell. The EGCG inhibits this activity and it degrades the fibrils, thereby lowering the transmission risk. The EGCG has also been found to inhibit a variety of HIV subtypes at a physiological concentration without damaging the human cell. When coupled with other nutrients like vitamin C and lysine, the green tea extract inhibited the production of HIV in chronically infected T cells. In latently infected T cells, combining the green tea extract with vitamin C and amino acids resulted in significantly greater suppressive action than when any of the three were applied individually. The powerful antioxidant lipoic acid plays a central role in the defense against free radicals. It also recycles other important antioxidants, including glutathione, and it decreases intracellular signaling that promotes inflammation. 300 milligrams of alpha-lipoic acid 3 times per day for 6 months significantly elevated blood glutathione levels in a group of HIV-infected men and women aged 44 to 47 years. In the lab, alpha-lipoic acid has been shown to inhibit HIV replication. Its ability to scavenge the reactive oxygen species has been found to block the nuclear factor kappa B, which is a transcriptional activator that's instrumental in the regulation of HIV gene expression. In a study by Merrin and Associates, applying alpha-lipoic acid to cells infected with HIV completely stopped the initiation of the HIV-1 induced by the tumour necrosis factor alpha. Acetyl-L-carnitine is also an antioxidant. It boosts immune function and it helps the body to convert fat into energy. A number of studies have reported the positive effects of the acetyl-L-carnitine in people with HIV, especially its positive impact on the side effect of certain antiretroviral drugs. People with these drugs often experience peripheral neuropathy or peripheral nerve damage and myopathy, which is muscle tissue disease. And these outcomes have been observed in trials, and they can discourage the patient from adhering to the medication regimes. However, the acetyl-carnitine might help to mitigate these effects. The acetyl-carnitine is known to be involved with peripheral nerve regeneration. In a small study, 2,000 milligrams of oral acetyl-L-carnitine each day for a month led to a significant reduction in pain intensity scores among HIV-infected patients when taking antiretroviral therapy. A larger study involving 90 HIV-positive patients with antiretroviral toxic neuropathy found taking 500 milligrams of acetyl-L-carnitine intramuscularly twice a day for 14 days resulted in statistically significant improvements in weekly mean pain ratings versus a placebo. When these patients subsequently took 1,000 milligrams of oral acetyl-L-carnitine twice per day for 6 weeks, the symptomatic improvements were observed. A cohort study involving 21 HIV patients with related neuropathy who were reviewed after receiving the acetyl-L-carnitine for 4.3 years found that 13 out of the 16 patients who completed the study reported very much or moderate symptomatic improvement, and 9 were pain-free. In a small study involving 21 participants who were receiving 3 grams of acetyl-L-carnitine daily for 24 weeks, it corresponded with improvements in subjective pain rating. Certain vitamins have amassed a notable amount of clinical evidence to highlight their potential supplementation value for people with HIV. Vitamin D has a multitude of important functions within the human body, including its role in supporting the proper immune function, regulating bone metabolism, and maintaining calcium and phosphorus homeostasis. In people with HIV, vitamin D deficiency is common, as is lower than normal bone mineral density. Additionally, people with HIV appear to be at an increased risk for osteopenia and osteoporosis. In a recent review of the medical literature, it was concluded that HIV infection should be regarded as a risk factor for bone disease. Deficient levels of vitamin D in HIV-infected individuals might be due to the virus itself, as well as the effects of the antiretroviral treatment. As people with HIV continue to live longer, bone loss prevention becomes an even more prominent consideration in the aging population. Some studies have shown a correlation between vitamin D status and the CD4 counts, while others didn't find this relationship. Interestingly, some studies that detected the vitamin D deficiency in HIV patients found that uninfected individuals also had low levels of vitamin D. In the US, vitamin D deficiency is highly prevalent in the general population, regardless of HIV status. For more on HIV and AIDS, herbs, supplements, and natural treatment plans, check out my website.